Terror, terror. Huh? Good evening, everyone. I'm Dr. Shashank Shah, laparoscopic and bariatric surgeon. And today we are going to discuss about mechanism of action of sleeve gastrectomy, which is also known as vertical gastrectomy. Sleeve gastrectomy is a procedure in which the surgeon removes the curvature of the stomach, and almost 70 to 80% of the stomach is removed vertically. It is much more than that. It's not just the small size of the stomach. We have published some papers which showed effectiveness of sleeve gastrectomy on Indian obese patients. It doesn't say morbidly obese. That means even Indian obese patients could respond well for the treatment of diabetes to sleeve gastrectomy. If you look at the anatomical considerations, it is vertical, it is small in size, the circular muscle is sutured by the suturing device stapler. So what happens is it becomes a high pressure tube, it is less distensible, the volume is less, and it has a naturally controlled outlet, that is the pylorus. The impact on weight loss, diabetes, metabolic parameters, everything is similar to any other bariatric procedure. We all know that the curvature of the stomach, or the greater curvature of the stomach, the fundus secretes a hormone called ghrelin, which is commonly known as a hunger hormone, a hunger responsible for hormone. Whenever that level of hunger hormone goes up, the person feels hungry. However, if you compile all the actions of that hormone, if effectively it's an obesogenic hormone and a diabetogenic hormone, and thereby by doing a sleep, once we reduce that part of the stomach and resect it, the hunger hormone or the ghrelin levels go down, and then it has an anti-diabetic and anti-obesity effect. Sleeve has a peculiarity that it has the pylorus preserved. The benefit of pylorus preservation is it not only gives restriction to solids, but even liquids can be held in the cavity, and the person's liquid intake also can be controlled, especially when the person is consuming any high calorie liquid or any other concentrated liquid. The passage is physiologic. There is always an antropyloric pump, and the pump's action depends on the size of the stomach, the volume of the stomach, the speed with which the food moves down. There were multiple papers published which suggested that there was equivalent weight loss at 1 and 2 years after sleeve gastrectomy, even compared to gastric bypass. However, there was greater loss of hunger, and there was greater loss of craving for sweets. That means something more than just the hunger hormone was seen in the results. Then we did a study in which we had 25 obese, morbidly obese people, 25 lean and normal people, and 25 who became lean after a sleeve gastrectomy, and we gave them technetium 99 for a swallow and tried to study the gastric emptying time and intestinal transit time. What we found that the gastric emptying time and the intestinal emptying time was slower in those who were morbidly obese, and it became faster after a sleeve gastrectomy. So something in the pump which worked as a pressure point or a trigger point created a wave, and the small bowel transit became little faster. These are the half times, T half times. Now, if you look at some of the published editorials, a rise in plasma ghrelin GLP-1 is the evidence for rapid transit. If you see ghrelin GLP-1 levels in the patients who have undergone sleeve gastrectomy, we find that there is increase in GLP-1 and PYY, and that's indirect evidence that there is rapid transit. And it is the amount, the pressure, and the speed of the first squirt into the duodenum which decides the extent of stimulation to duodenum and further areas, which eventually a hormonal stimulation. There is markedly reduced level of ghrelin as well as increased levels of PYY, and they lead to fasting as well as postprandial hunger suppression and increased satiation. This is a distinct action of sleeve gastrectomy. So we looked at the reduction in hunger hormone ghrelin, increase in GLP-1, increase in PYY. All these improve the eating behavior, and this is a three-factor eating questionnaire. which you are saying, which was conducted in the study. And we found that the three-factor eating questionnaire showed improvement in eating behavior whenever there is rapid transit, that is, on those who underwent sleeve gastrectomy and those who were lean. This is about PYY. It is a 36 amino acid straight chain polypeptide. However, PYY 336 is most important. DPP activity, DPP4, dipeptidyl, DPP activity is increased in the obese. Obesity decreases both basal and mean stimulated PYY levels. The PYY levels increase after sleeve gastrectomy is because DPP is responsible for cleaving the PYY 136 into PYY 336. Factors important for impact of any procedure, any treatment on type 2 diabetes would be the weight, the extent of adiposity, whether the patient's pancreatic beta cell function is well preserved, ethnicity, body composition, and the C-peptide levels. And there would be other factors as well. All these factors together decide whether a particular treatment will be extremely effective in treating someone's diabetes, and more so when we are looking at resolution or remission after bariatric procedure. We see combination of sleeve gastrectomy whenever it is added to other procedures like one anastomosis gastric bypass, vertical banded gastroplasty, duodenal switch with sleeve gastrectomy, duodenal jejunal bypass with sleeve gastrectomy, ileal interpositions with sleeve gastrectomy. Whenever a sleeve was added, the effectivity of the procedure improved. Probably it could be because addition of a sleeve would add restriction and would still further improve the transit of the small bowel. There are multiple actions of how a sleeve gastrectomy works. It's not only the restriction, that means the amount of food consumed by the patient at a time reduces, but there is reduction in the hunger hormone, reduction in cravings, the increase in GLP-1 and PYY give rise to increased satiation. Long time the person can sustain the satiation. There is rapid gastric emptying and rapid intestinal emptying, giving rise to relative malabsorption. Of course, because the pH of the fluid which enters from the stomach to the intestine changes, there would be change in bacterial flora, there would be change in the bile acid levels, and there are multiple other mechanisms which are being proposed like vagal stimulation. This is under evaluation, under research. However, one thing is definitely understood, that it's not the reduction in the size or restriction alone that is responsible for actions of sleep, more so on the diabetes. The benefits are sleep has a lesser learning curve. It's a simple procedure. There is less malabsorption. There is higher satiety. It is well tolerated. There are lesser nutritional deficiency in multiple procedures in high risk patient, in complex procedure patients. This could be an easier procedure. The weight loss, the diabetes result, the metabolic benefits, they are all satisfactory. Very long term results are still awaited. Of course, it is not reversible, and if there is a complication like a leak, it is very difficult to treat. Large hiatus hernia or a significant reflux disease is a relative contraindication. These are few patients, super obese, who underwent bariatric surgery in the form of sleeve gastrectomy, and you can see their results at that time. Thank you so much. Let me address some of the questions which were generated. Is it curative for diabetes? So, if the patient's BMI is high, the C peptide levels are more than 2, pancreatic beta cell function is well preserved, and there is high amount of insulin resistance, those patients definitely will have good remission. Now, how does this procedure improve glucose homeostasis? We know that if a person with diabetes eats less, diabetes gets better control. And this restriction does add to control of diabetes. The reduction in ghrelin will have improved satiety as well as hormonal actions to stimulate pancreas to secrete more insulin. Same with GLP-1. It is an incretinomimetic or an incretin, and that is how the procedure itself becomes incretinomimetic procedure, a hunger hormone reducing procedure, and that is how it improves glucose tolerance. Patient selection criteria. In terms of patient selection criteria, what role does patient's age associated comorbidities play? This is a very important question. Actually, there is no single procedure ideal for everyone. One has to select. So, if you have to select a patient for sleeve gastrectomy, maybe someone whose BMI is more than 32.5 and has comorbidities. That is someone who's morbidly obese, maybe diabetes duration less than 5 years, not insulin dependent, maybe a non-smoker, and a person with very good C peptide, person without reflux disease can undergo sleeve gastrectomy. Any patient who has multiple laparotomies, adhesions, hernias, wherein handling of intestine would be difficult, could undergo this procedure. And in very high risk patients, this could be a first stage procedure. What is the impact of this procedure on the cardiovascular outcome is the question. Obviously, this procedure would improve long-term cardiovascular outcomes, and reduction in intake would reduce the lipid levels. The insulin resistance will reduce. Obesity is known as an inflammatory disorder, and these procedures work as anti-inflammatory procedures, and then the levels of TNF alpha and many other inflammatory markers which are atherogenic goes down. Diabetes improves, hypertension resolves. All factors which are responsible for cardiovascular risk slowly start improving and go into resolution, and this is how cardiovascular outcomes can be improved. Is there any specific pre and post operative guideline that need to be followed by the patient? Yes, all these bariatric procedures have a protocol of diet guideline. They are more strict only in the first 6 weeks when there is internal healing taking place. That is, in the first phase of 10 days, patient has to be on the liquid diet. In the next 10 to 15 days, person can have thick liquids or pureed food. The next phase could be soft diet, and maybe by 6 weeks, person can start consuming everything. Of course, the most important care is patient has to be conscious of what he is eating and it should be as healthy as possible. Thank you. Done. Thank you so much. And I must thank Docplexus for giving this opportunity. Done. Done. Thank you. Good beta. Still I covered everything.